in listen-only mode.
Good afternoon and welcome to today's webinar. TVN Webinar Series is a regular forum where Canadians and international experts share the research and insights on advancement in assessing and caring for frail elderly Canadians. This is probably our 10th or 11th knowledge synthesis grant, and today's presentation is a knowledge synthesis grant as well. Just to update for research and fellowships, the 2015 Catalyst Grant, the Notice of Intent has passed, but Monday, November 9th, the full application is due. In the Transformative Research Grants, the full application is due by December 1st, and our new one-year fellowship is due October 23rd. Originally, it was due on the 16th, so please take notice of the 1 week. And the TVN Frailty workshop at the CHPCA conference is coming up October 29th, and you can still register for that. Just for everybody who's new to these webinars, that you're able to submit questions online during the webinar, and we'll try to answer as many as possible after the presentation. A brief survey will pop up on your screen within the next few seconds, and we're looking for feedback on how we can improve the webinar series. And we have a few scheduled webinars coming up. You can also see them on our website, and we will be adding more starting January, February, and March. We're just in the process of setting up the research grants that have just completed and have some success stories to share with the audience. I've got the next one. And then today we have 3 people presenting, as well as Louise Hanvey will be commenting afterwards. So John Yu, I'm sure everybody knows, is an internist, oh my goodness, internist and staff physician at the Hamilton Health Sciences, and Associate Professor of Medicine and Clinical Epidemiology and Biostatics at McMaster University. We have Simon Oczkowski, who is a clinical scholar in Division of Critical Care at McMaster University as well. And we have Hanno Chung, who's a critical care physician at the Hamilton General Hospital. And I think, John, you're going to explain more on their participation. So we're changing the screen over to you now, John.
Okay, can you hear me?
I can hear you, yes.
Good. Hi, everybody. Is the control panel blocking the screen, or can you see my slides?
I can see your slides.
Okay, good. There we go. Okay, perfect. So thank you, everybody, for joining us. This is John Yu here. This is going to be a webinar that presents the findings of a knowledge synthesis grant, as Carol was explaining. My role was sort of a supportive advisory one, and I really want to thank Hanno Chung and Simon Oczkowski for doing the lion's share of the work on this project, and in fact generating a lot of, really generating the idea to do this important work. And so it's a real pleasure to share this opportunity with them to tell everybody about what we did and what we found. So they really have done like 90 to 95% of the work and should take the credit for all of this. Thanks also to Louise Hanvey, who is our knowledge user partner at CHPCA with the National Advanced Care Planning Task Force and the Speak Up campaign. Louise will say a few words from a knowledge user perspective at the end. And Lawrence is not here, but I think I'd like to thank him publicly for his statistical advice and methods advice. So, in terms of an overview of what we will cover in the next 35 minutes or so, I'll present a brief background of what motivated us to do the review of this knowledge synthesis. And then I will turn it over to first Simon and then Hanno to discuss findings from our review, sort of describe what we did and what we found in two areas. One is around end-of-life communication tools in the ambulatory care setting, and the other major area was educational tools or interventions for healthcare providers around end-of-life communication and decision-making skills. And then we'll have a broader discussion and hopefully a group discussion about the implications of these findings. I was told that in a good presentation you should actually give the conclusion first so people know where we're heading, so I'm going to do that. Basically, what we found in the knowledge synthesis is that the available evidence through this review is suggesting that, in general, available communication tools for end-of-life decision-making are effective on a number of outcomes. But the important caveat is that the quality of that evidence is low. And I think one of the discussion points is, given that, what are the implications for practice, policy, and research? So now to just take a step back and give some context for why we did this. So, you know, this is TVN, and we are interested in care of seriously ill, frail elderly. And there's been some important work done by the CareNet research group, led by Darren Hyland, looking at the perspectives of seriously ill, frail elderly and families in hospitals, asking them what's most important to them in defining high-quality end-of-life care. And this important study in the Canadian Medical Association Journal found that if you ask these patients and families directly what's important, these are some of the items that they report as extremely important in end-of-life care. I won't read them all out, but you can see them here on the slide. And I think as you go through them, example, receiving information in an honest manner about their disease, having trust and confidence in the doctor looking after them, what patients and families, I think, are saying loud and clear is that they want good end-of-life communication and decision-making during serious illness. And yet we know from a number of studies, and in the interest of time, I'm not going to go over 10 slides of different literature, but it's quite clear from landmark studies such as the support study in 1990s, more recent work in Canada by the CareNet group and others, that end-of-life discussions about use or non-use of life-sustaining treatments are often too little, they're too late, so sometimes like documentation of code status like 48 or 24 hours before death amongst critically ill patients, and that the quality of these discussions is not great. For example, in a fairly recent study that I was involved with CareNet, we found that seriously ill patients in hospital could express a preference for life-sustaining treatment, and that most of the time, in fact about 10 to 12% of the time only, that their preferences include CPR, and yet 70% of the time the prescribed medical orders for life-sustaining treatment were discordant with patient preferences. And this was due to inadequate communication and decision-making with their care providers. And so with these existing gaps in communication and knowing that patients and families are still wanting higher quality communication and decision-making, that was really the motivation for doing this review, to see what kinds of tools or interventions are out there to address this gap and how effective are these tools. There was a recent systematic review in the Annals of Internal Medicine that was funded by the Agency for Health Research and Quality, AHRQ, that was very focused on specifically decision aids. And Simon and Hannah will get into our review. Ours was broader than just decision aids. And they looked specifically at decision aids for advanced care planning. And it wasn't a formal systematic review, but it was more of a, I forget the name of their methodology, but it was it's more of a scoping type review. And they essentially found that there's often inadequate empirical evaluation of existing tools, and that greater evidence is needed about the effectiveness of tools. But they didn't provide sort of quantitative estimates or a rating of the quality of evidence that was out there. So it was an important piece of work, but I think left some questions unanswered. So with that in mind, the objective of the review that the three of us did was to conduct a formal systematic review to determine the impact of communication tools for end-of-life decision-making, and Hanno and Simon will get into the details of this, compared to usual care on either communication and decision-making processes or relevant downstream patient outcomes. So I'm going to turn it over first to Simon and then to Hanno. Simon's going to talk in more detail about what we did and then what was found in one of the components of the review, and then Hanno will do the same afterwards. So over to you, Simon.
All right. Thanks, John. So for our systematic review, having looked at the literature, we tried to figure out, we saw that there were some gaps. One of the things that we noticed was in terms of communication tools, there's formal decision aids, things that, you sort of talk to a patient or a family and you say, what are your values and preferences? Here are your likely outcomes. Now we're going to end up with a preference for or against life-sustaining treatment or for certain aggressiveness of care. But we recognize that there's a lot of interventions that don't fit into that traditional mold. So we sort of broadened the scope of our review to include communication tools. So this could include things, not just formal decision aids, but also, for instance, structured meeting plans where, a clinician would meet with a patient or a family member and discuss end-of-life preferences, but there was no decision aid per se, but it was sort of a more structured approach to decision making. Could also include things like mailings and reminders as well. So we wanted to really broaden the scope of the interventions we were looking at, recognizing that decision aids are really just a small part of what we can do to help patients and family members with end-of-life decision making. At the same time, we also thought it was important to exclude tools that, although they're there for the purpose of improving communication between healthcare providers and patients and families, they didn't specifically help with end-of-life decision-making. So those would be communication tools that looked at information sharing, things like breaking bad news. So when we put our inclusion criteria together, we specifically wanted randomized controlled trials or prospective observational studies in the English language with adult patients, and that compared communication tools of all those different types I just mentioned to control. And control was, in most instances, usual care, but we recognized as well that in some cases it would be important to have either a sham intervention or a minimal or low intensity intervention because depending on the intervention studied, some REBs might not allow advanced care planning versus no advanced care planning, recognizing that's an important process in and of itself. We searched multiple databases, including the usual Medline, Embase, Cochrane, CIN-AHL, as well as the educational database, ERIC. From the database inception up until our study began in July 2014. And we screened, we did eligibility independently in duplicate. Hanno and I did all of this using standardized piloted eligibility forms. My wife saw me working on those for many, many hours. And then when we had these studies, we recognized as well that many of them would be relevant to different populations. So we divided into our studies into 4 groups. There's the ambulatory or outpatient population. There was the hospitalized but non-intensive care unit type of discussion. There were interventions that took place in the intensive care unit, and then there were interventions that aimed to improve end-of-life decision-making by specifically educating healthcare providers. And so today we're going to talk about the first and last. The second and third topics, the inpatient and ICU studies, we're not going to discuss today for the purposes of time. The outcomes that we used obviously varied from setting to setting. So when we talk about the ambulatory and educational, we'll go over what our primary outcomes were in those settings. We collected data using standardized case report forms that we created online. And in terms of assessing study quality, we used the Cochrane Risk of Bias tool for randomized control trials, the Newcastle-Ottawa scale for observational studies, and the NIH tool for uncontrolled before-after studies. So those are basically pre-post studies where participants acted as their own control. And then for each of the outcomes of interest, we assess the quality using grades. So grade stands for grading of recommendations, assessment, development, and evaluation. And I recognize there's a lot of knowledge users, so I just want to talk very briefly about what grade does. So as opposed to assessing the quality of an entire study, grade is used to assess the quality of evidence for a specific outcome. So grade looks at the risk of bias across studies, so things like publication bias. It also looks at bias and the direction of that bias within each study. It looks at the imprecision of results, the inconsistency of results between studies, and the indirectness of the results. And by doing so, we were able to come up with an assessment of the quality of evidence, not just of the studies we looked at, but for each outcome of interest that we had. In terms of our data analysis, and Lawrence was a great help in this regard, we gave priority to randomized control trials, as those are the highest quality evidence that we had available to us, and used standardized mean difference and mean difference for continuous variables, and risk ratios for dichotomous intervals. Specifically, for our pooled estimates, we used data from low and uncertain risk of bias, RCTs, and pooled that data. But we also, for our sensitivity analysis, included high risk of bias studies. So these were individual RCTs at high risk of bias and observational studies. So we essentially did two sets of analyses, one with the lower risk of bias studies, and we got a pooled estimate there. And then we do a second sensitivity analysis having the higher risk of bias studies to see whether or not that changed our results. And then we assessed heterogeneity by looking at the studies and using I-squared values. So in terms of our results, so unfortunately it's a little bit blurry, but we found 5,727 articles through our electronic searches and 58 through manual search of the references. We screened all of those titles and abstracts, finding 366 articles for full text review, of which 168 met our final eligibility criteria. Of those, 67 studies were conducted in the ambulatory setting, 18 in the inpatient non-ICU setting, 19 in the ICU setting, and 20 in the education setting. We also found a number of qualitative studies that we can use for future review. And of note, some of the studies overlapped between education and the intensive care and inpatient setting. So there were a couple of studies that looked at an educational intervention for healthcare providers and then went and looked in the ICU and went and looked in the hospital to see whether or not the education of healthcare providers affected patient outcomes. So there were some studies that actually overlapped between those. So now I'm going to switch gears and talk very specifically about our results in the ambulatory care setting studies. So our primary outcomes here, there were three, each one looking at a progressively more focused on patient outcomes. So the first one was completion of advanced care planning. So this would be completion of a document or a documented discussion in the medical record. The second outcome is whether or not those advanced care planning documents and discussions led to medical orders for care. So if you had an advanced care directive, when they looked in the medical chart, did that lead to a patient having medical orders with life-sustaining treatment or not? So did your advanced directive lead to you having a DNR or a full code status in the chart? And then the third one was, did the patient wishes actually result in changes in the care they received, which is probably the most patient-important outcome of the three. So when you look at the studies we found in this setting, they ranged in publication from the 90s up until the very near the end of our search parameters. The vast majority were conducted in North America, with a few in Asia, Europe, and Australia. The majority of studies didn't actually investigate patients with any specific medical condition, so 58%, but significant minority of studies did look at patients who had cancer, cardiac disease, renal disease, COPD, and a smaller number with neurologic disease, including dementia and also HIV. And the interventions were quite broad in scope. As we mentioned before, we wanted to get the full spectrum of end-of-life communication tools. And so because we wanted a broad selection, we actually ended up with a very broad variety of interventions. So some of them were simple verbal communication tools, some were paper-based, some were a combination, a significant number were video and computer-based, some were very complex multimodal quality improvement interventions, and 3 of them were healthcare provider directed, but were not explicitly educational. For instance, computer prompt lists for healthcare providers to discuss end-of-life decision-making. The quality of evidence is summarized in these 2 very large tables. Just sort of glancing the one at the left, so the green circles refer to a low risk of bias in that domain, yellow uncertain, and red high risk of bias. You can see that there are many studies that are of have high risk of bias in some domains, many uncertain risk of bias because some of the studies were quite old and we either couldn't get in contact with the investigators to clarify. And there's a fair number of studies that are actually fairly good quality. If you look at the table on the right, so that is the observational studies for which we use the NIH or the Newcastle-Ottawa scales. And again, the studies were of mixed quality, but generally pretty good. So moving on to our outcomes then. So the first one was the proportion of patients that had documented advance directives. So this is a forest plot. The top 4 studies are the low risk of bias studies, and the bottom portion is the unclear risk of bias studies. And we split our results up into these just to see whether or not the risk of bias would affect the results. At the bottom there, you actually see there is a significant improvement in the proportion of patients who had documented advance directives with the use of these tools. So the risk ratio is 1.92 with a 95% confidence interval of 1.43 to 2.59. The caveat here being that there's a significant amount of statistical heterogeneity, which isn't due in part to simply the heterogeneity of the interventions being studied. But when you look at it, most of the heterogeneity has to do with the difference between either very large and small beneficial effects. So those are the plots on the right side of the graph, as opposed to positive and negative effects. So overall, it does seem to be of benefit in terms of the documented advance directives. These are whether or not advanced care planning discussions were documented. So not a formal form being filled out, but whether or not in the medical chart patient wishes and the discussion had been recorded. And again, you see that there's a significant amount of heterogeneity between the results. However, it's really between large and small effects than between positive and negative effects. And then there's very few studies that we could actually find that looked at whether or not these communication tools for end-of-life decision-making actually had an effect upon the care patients received at the end of life. So in fact, we only found 2 randomized control trials, one at low risk of bias, one at unclear risk of bias, but both were actually very small. When you pool the results together, you do see that there is an improvement with concordance between the care preferences of the patient and the care received at the end of life. but it is a very small effect with a risk ratio of 1.17. And in part, I mean, this is probably one of our most important outcomes, but it's one of the most difficult to study and had the fewest studies reporting that result. So we have a number of secondary outcomes as well, but for the purposes of time, we're just going to focus on those primary outcomes. So if we're just going to summarize what we can say about the ambulatory care setting is that there's a very wide variety of communication tools that have been evaluated to assist with end-of-life decision-making. And it seems as though these tools can increase the completion of advanced care planning and documentation, as well as some of the downstream patient-level outcomes, specifically concordance between the care patients wish to receive and the care they do receive at the end of life. But the quality of evidence is very low. So when we sort of thought about, well, how can this apply to practice? Because of the low quality of evidence, we think that the use of these tools can be considered, especially if you're taking care of populations similar to those in the studies. But the effectiveness of their use and the type of tool used needs to be tailored to your local context. We also think that given the low quality of evidence and the fact that there was heterogeneity between some of the studies having a very positive effect and some of them having a very minimal effect, I think that if you're going to take the time to implement a tool like this, you should monitor and ensure that the desired outcomes are being met, because this evidence is not guaranteed that if you implement a tool like this, you will receive the benefits and the patients will receive the benefits you want. So you need to really monitor that. And with that, I'm going to hand it over to Hannah, who will discuss the educational interventions.
Thanks, Simon. Hello, everyone. My name is Hanno, and I'll be discussing the healthcare provider educational intervention portion of our systematic review. So we know that communication skills is a critical aspect of any successful end-of-life discussion interaction. And universally, we found that whether you are a medical trainee or even an active practitioner, that there's a sense of discomfort and ill-preparedness in actually achieving this. So this question is focused more on the healthcare practitioners. What is the effectiveness of end-of-life communication skills training for healthcare practitioners or providers compared to standard curriculum, and in this case essentially means no formal curriculum. This portion of the systematic review was done a bit differently, partly because the methodologic traditions of education reviews are a little different. The main thing that you'll see is that partly because there's not a lot of studies available, the randomized controlled trials and observational trials are pulled together. We'll talk about that in a little more detail. The outcomes here are also adjusted to be relevant to the educational setting. So we chose to classify it based on the Kirkpatrick education or evaluation model, which you can see here, the base being reactions, then learning, then transfer, and finally up to the results. So when we put that into our educational outcomes, here you see our primary outcome, and the level 1 or reaction will be that of self-efficacy. So essentially the reaction measures how your trainees react to the training, if they felt that the training was subjectively valuable experience to them, if they feel good about the educational experience. So in this case, self-efficacy is a sense of a self-confidence in their abilities to do end-of-life communication. At level 2, you measure what the trainees have learned. And so how much of their knowledge, how much has knowledge increased as a result of your training? And this is usually in the form of a standardized test. And in this case, it's measuring mechanistic understanding of advanced directives and advanced care planning. The third one, or what we call transfer, is evaluating how your trainees have changed regards to their behavior with the training that they received. So specifically, it looks at how the trainees apply the information or the training intervention that you gave them. So in this case, the outcome was a communication score. So they were looking at the process measures of what's involved in a good end-of-life communication. So it's in the form of a checklist score with a standardized patient encounter on what's deemed to be a good interaction. The final level is that of results, and that's on an institutional or an organization level. In these studies particularly, it means patient-level outcomes for the most part. So medical education studies generally are not powered to detect this level of outcome, whether because the follow-up is not long enough or there's too many variables between the study intervention and the patient outcomes that it's diluted. So we won't be really talking about this secondary outcome in this webinar. In brief, the majority of the studies were based in the US. And you can see here, again, also a lot of the studies were postgraduate level training, so that would be residents and sometimes fellows. Some of these studies included undergraduate medical education, that would be medical students, and the sprinkling of them included active physician practitioners and also other frontline healthcare professionals. 6 of the studies included were randomized controlled trials, and 14 of them were prospective observational trials. The instructional design was also varied, but actually a vast majority of them used very similar design. So delivery methods included a didactic lecture and overview. They had small group breakout sessions as well as role-playing. And the instructional methods usually involved group discussions and observed feedback. Half of these studies used a distributed practice, and the other half were focused whether in a half-day or just a couple of hour workshops. Regarding the quality assessment, so with the randomized control trials, they were done similar to the previous ones that you saw using the Cochrane recommended risk of bias scales. However, in addition, all of these studies were measured using medical education specific quality instruments. So they would be the medical education research study quality instrument or the education specific Newcastle-Ottawa scale. And the reason both of these were used, even though they're independent assessments in their own right, is that they focus on different aspects of quality. So the Mirsky scale would focus a little more on objective versus subjective outcome assessments, and the Newcastle-Ottawa focuses more on blinded versus non-blinded assessments. Here are the tables. On the left, you see the studies that were randomized, and the next one was on the right are your observational studies. In general, the Cochrane risk of bias tool showed that all of the randomized trials, none of them met criteria for low risk of bias, and 3 of them were high risk of bias, so half of them. And similarly, when we looked at all the studies together, only half of them met criteria of high-quality studies by threshold of the Mirsky instrument or the Newcastle-Ottawa. So here we're looking at the primary outcome of self-efficacy. Again, that means the sense of self-confidence in their abilities. And the standardized mean difference is 0.57, which is considered a moderate effect size. As you'll see from here and all of our outcomes, because all the studies had very different types of quality and different types of methodology, we did look at a sensitivity analysis looking at studies that have are only randomized controlled trials or have high methodologic quality using the Mirsky or the Newcastle-Ottawa tool. And all of these sensitivity analysis shows that the magnitude and the direction of the effect essentially remain the same. So in terms of the self-efficacy as an outcome, it's measured quite commonly, probably because it's one of the easiest things to measure. You give a student a survey of how they felt before and after. However, you have to be careful interpreting some of these findings. Self-competency, when measured by the person themselves, generally do not correlate well with real life. You can imagine, it's difficult to imagine somebody going through all the time and effort to learn something and at the end of the learning session feel like that they haven't learned anything. So in that sense, it's usually biased towards the fact that they felt like they've learned something. And indeed, when we look at studies that were done in the mid-90s, specifically looking at end-of-life communication, people's sense of self-confidence or abilities did not correlate with their actual abilities to lead these discussions. However, self-efficacy is useful in the sense psychologically when people have negative expectancy or they have a low sense of confidence in their abilities, they actively withhold beneficial communication behaviors. And so as we discussed previously, when there is so much of a hesitance to instigate some of these end-of-life conversations to begin with, potentially improving a sense of self-efficacy can decrease these barriers. The next outcome is that of knowledge, and the standardized mean difference was 0.76. Again, it's a moderate effect size. And similarly, we saw that across our sensitivity analysis. Again, this is an outcome that we have to be careful about. It's very easy to administer evaluation, but it's not necessarily contextually relevant for communication skills training. We don't necessarily know the exact content of what they're tested on, but you can imagine the learners might cognitively know what's entailed in a end-of-life communication, however, not have the necessary skill set to carry them out in real life. So increasing knowledge doesn't necessarily improve communication skills. This is the sensitivity analysis, as we talked about. Finally, the last primary outcome is that of a communication score in the form of a checklist score with standardized patients. This is a bit of a reductionist approach where they're quantifying features within a standardized patient encounter which is predetermined to be important in an end-of-life discussion. Overall, you see here the standardized means difference is 0.69. We did see high levels of heterogeneity in this group. We tried actually qualitatively looking at different delivery styles, different methodology of the studies, instructional methods, the demographics. Unfortunately, we couldn't actually explain away the heterogeneity. Also, the outcome measures for communication scores a lot more resource intensive compared to the previous two outcomes that include standardized patients and more assessors. However, I think this is overall a very important outcome to look at compared to the other two because it shows that there is a genuine behavior change when we have end-of-life communication skills training. And I think this is a practical way to assess the efficacy of the training program as well, because previously, as we said previously, when we talk about the next level or patient-level outcomes, it's not always a feasible thing to do. So as we have better understanding of some of the important things that patients and families think are important in an end-of-life discussion, we should hopefully have better scoring instruments for communication. Again, some caveat. What I did wish these studies included is also not only this checklist score, but a qualitative global assessment as well. Checklist scores are easy to measure, but they also don't necessarily correlate with expertise. So somebody that is highly competent or is an expert in this field may shortcut some of the things that are in the checklist for the greater good of the overall communication. And so even though the overall interaction may be qualitatively better, paradoxically the scoring in a checklist might be worse because then compared to a novice who methodically goes through all of these checklist scores, but in the end lacks the finesse or the nuance that an expert might have. So I hope in future studies, when they include a communication score, that they also include the counterpart of a global assessment as well. So in conclusion, again, I didn't go through the grade evidence, but overall the evidence, because of the overall low quality of evidence and in the small number of samples, the evidence is low to very low quality. But there is an association with improved learning outcomes compared to informal curriculum. But let's be honest here, when we talk about informal curriculum, we really mean no training or no teaching whatsoever. And so that's the bigger implication here, is that this is an important skill set that we're expecting of physicians and a lot of frontline healthcare professionals. And the big limitations of these kinds of studies, which we call justification studies, is that we're looking at a very almost pedantic question of, if we teach them something, will they learn more than if we do not teach them anything? So invariably, the answer is that it will it will be yes. So the better use of research resources in the future should be against an active comparator, because I think most of us will agree that this isn't a matter of if we should teach this topic, but really a question of how should we be teaching this topic. So a lot of these studies are very resource intensive, including an assessor, retreats, and standardized patients and manpower. And so we need to really see what forms of these training interventions are more effective than the other. So I hope in the future studies that they focus in this area, focus on good methodologic quality, and look at more contextually relevant outcomes. Thank you. I'll pass it back over to John.
Thanks, Hanno. Thanks, Simon. Again, a tremendous amount of work that you've both done. Very impressed. So I was reflecting as as Simon and Hanno were both speaking now, and of course as we were doing this work and looking at the emerging findings, trying to understand what are the implications of what was found in this knowledge synthesis as it relates to tools in the ambulatory care setting and educational interventions. How should it influence our current practice, current policy, and future research? And in a very timely fashion, earlier this week in the New England Journal of Medicine, Scott Halpern published a perspective or editorial making a call for more evidence-based end-of-life care, and talking about some of the limitations of the existing evidence base around interventions in the end-of-life care space. And it was, I think, very timely and important for him to highlight these issues. And I'd encourage you to read it. It's extremely well written. And so with that in mind, again, sort of the key message that kind of came out to me in listening to what Simon and Hanno found is that when you systematically comb through the world literature, really looking at a broad array of communication tools to support end-of-life decision-making, the overall signal seems to be that there is an effect on some important outcomes, perhaps less evidence on the more downstream and even more important outcomes. But in particular, that the overall quality of evidence in this area is low. And what do we mean when we say low quality evidence? And when you talk to people like Gordon Guyatt, who created this grade system for rating quality of evidence, I would say essentially quality of evidence you can translate to confidence in the effect. Like, what's your confidence in the effect? So in this case, we're saying that these things probably work, but our confidence in the effect is low because of limitations of the work has been done. And so given those findings, I think there's still this very real environment that we're currently in. There's a policy window or a current, what I sense is a great interest in trying to improve, and I certainly share this desire to improve the quality of end-of-life care and achieve better decisions and more discussions. And I think there's this real feeling amongst many organizations at many different levels that really we should be doing something to address this. And I guess the tension for me in looking at the emerging findings from this review are, yes, we feel like we should do something now, but given the low confidence in the effect of some of these tools and the fact that implementing any kind of tool like this in practice does take resources, how should we move forward? Should we say, well, this is good enough evidence, this is really important, we should just get on with it and start implementing stuff? Or is that going to be a misplaced allocation of resources if we don't truly understand which tools work best and how? The trade-off being, if we spend all our time kind of doing research, how can we make an impact on real-world practice? So I'm not saying I necessarily even have an answer to that, but it's sort of where my headspace is right at this moment. And I'd be very interested in hearing from the audience about where they sit in this debate of, you know, should we get on with it, or how much research needs to be done still, given what we found. I thought at this point it would be very useful to hear the knowledge user perspective in terms of how to interpret these findings, and then open it up to the group. So I'm going to hand it over to Louise. That ends the formal part of our sort of research presentation. So Louise, and then I think Carol will moderate a discussion for the remaining time. Thank you.
Great. Thanks so much, John and Simon and Hanno. I really appreciate you doing this work, and it's incredibly useful for us from the perspective of advanced care planning in Canada and trying to work on a national campaign. And I was really encouraged when I saw the audience attending this webinar that there's a lot of clinicians and administrators in the audience, so I'd be really interested in hearing sort of your perspective on it. But I just wanted to put out a few thoughts that I had over the time I've had to look at this information. And as John and Simon and Hanno have said, that it looks like, the tools and the education are effective, but the evidence is low. So as John said, we have this tension about what to do next. And I think we need to put it in a context that will help us, utilize tools and look at education. So there's lots of tools to choose from. This study showed that, and we know there's lots out there and lots of education programs. I really think we need to be careful and look at how these tools fit. So we need to ask ourselves, where are people on the conversation continuum? Are we talking about advanced care planning, which is exploring values, expressing wishes for future care, and communicating with substitute decision makers? And then, or are we looking further down on the continuum at goals of care conversations, which could in fact end in medical orders for care at end of life or at other times for that matter. The second thing we need to be very careful about is our jurisdictional legal framework and what is possible in terms of advanced care planning, documentation, all of that kind of thing within our province or territory. And then finally, as has been said, we need to look at our local context, and that's both an institutional and a patient population and family-focused context, but also our community context and what resources are out in the community and how can they work together to in fact make these interventions, if we're going to use them, more effective. And finally, what are we trying to accomplish? And we really need to monitor that. And we're trying to accomplish different things when we're using advanced care planning tools than we are, for example, when we're looking more at medical orders for scope of treatment. So I'll leave it at that, and I look forward to our discussion.
Okay, thank you. I would like to add thanks to John, Simon, Hanno, and Louise, your comments as well. I have a few questions from the audience, and I know we have limited time, so we might not be able to answer all of them, but we'll try. So the first question I have for either John, Simon, or Hanno is, are structured communication tools for end-of-life decision-making ready for prime time? That is, broad dissemination and implementation.
So that is the crux of the question I have in my mind, to be perfectly honest. And well, I'll let since Simon and Hanno did so much of this work, I'll let them give their perspective, and I'll also share mine. You guys might have to speak up a bit because I'm where the mic is.
Yeah, I mean, so it's Simon here. So, looking at and having combed through this evidence and looked at, literally hundreds of studies. Looking at how we can improve end-of-life decision-making in various populations. I mean, my sense is that these tools can be effective, but we don't know necessarily when and if they're going to be effective when you implement them. So I think there's two things you have to look at. First is you have to think, what are the resources available to us in whatever circumstance you're in. So if you're in a clinic, for instance, that tends to be taking care of lots of frail elderly patients or patients with life-limiting conditions or at high risk of disability and death, it probably makes more sense to spend resources and time developing or adapting a tool to your local environment. At the same time, though, having looked at it, some of the effect sizes that these tools have, even when they're positive, are pretty limited. So I think it's important to think, well, what are we trying to accomplish? What are our goals? And then measure to make sure you meet those goals. So I think, they're ready for prime time, but it's more of like in terms of a niche market as opposed to something that's very easy to disseminate across many outpatient settings. And that's specifically, I'm talking about the ambulatory care setting there. It's more like HBO as opposed to NBC. It's like a very specific focused cable network. You could have an intervention as opposed to this is something that every clinic everywhere should be implementing broadly. If that analogy makes sense.
Okay, I think that the second question might kind of add to that is, how do you think clinicians or policymakers should apply results of this knowledge synthesis to practice or policy development?
I think at the, at a clinic, like thinking about, for example, the ambulatory care setting where, we looked at end-of-life communication tools and that review in the first half of the results. It's John here. I think so first of all, I think we didn't look specifically at these data in this review, and maybe it's a limitation, but in terms of harms, I've not come across any compelling evidence that advanced care planning does harm. So I think really the harm is the resources that it might take to implement the tools. But in terms of patient level harm, I don't see that this as an intervention that is causing harm. And there seems to be signal, albeit confidence is somewhat low, that these interventions may have a positive effect or a benefit. And so I think the question at a say a clinical practice level, if you're a family physician's office or a family practice group, I think the issue is how to select a tool that meets that practice's needs and their patient population's needs as tailored to their context. I think Louise was starting to allude to the need to tailor. And so, number one, tailoring the intervention to local context, and then having an approach to implementation and monitoring that's kind of mindful, so that there's some process set up to, whether it's plan, do, study, act, quality improvement mindset, or something similar, so that as a group, practitioners are just not doing willy-nilly this or that, but that there's some structured process to see to try something, see whether it's worked or not worked, based on some preset metrics, and then course correct over time to see if you're having the desired impact. I mean, that would be my reflection of what could be done in the here and now, because I don't think it's realistic to think we should sit around waiting for more research evidence forever and ever. It's too important a topic to just sit on our hands. So that's kind of my take on it.
Okay, thank you, John. Given the available evidence uncovered by this knowledge synthesis, where do you think future research should be directed? Which kind of ties into what you were just saying, is,
Yeah, I mean, I think Hanno and Simon really highlighted, and in these particular areas, and remember, we only presented the data because it was such a large number of studies and a large volume of work that they did. We looked at, in terms of the ambulatory care tools, I think, in terms of future studies, I think the holy grail and what's missing is does this ultimately impact on patients' downstream care and the outcomes that are most important to patients? So it looks like there probably is an impact on, upregulating the amount of advanced care planning that gets done, the number of forms that get signed, but whether that translates to better quality care and more patient-centered care downstream, I think that's a lot less known and more tenuous. So I think in terms of future research, it'd be great to see that we can be more confident that these interventions have an impact on downstream stuff. And then in terms of the education of providers, I think Hanno hit the nail on the head. Like, I don't think there's a question of should we be teaching providers how to have these skills, but the question is, what are the most effective ways of doing it? And the current studies haven't head-to-head looked at, method A versus B. They've looked at method A versus nothing. So in terms of what could be done in the future, I think it's really to tease apart, well, what methods are effective or more effective than others, and it'd be great if you could show that less resource-intensive methods can still be effective, and more scalable methods of training can be more effective. But I think that's an open question.
Okay. I have another question asking about if there is more research done in Canada that demonstrates cost effectiveness of ACP, and basically saying the more recent research, and were they respecting patients' wishes and clinical utilization, etc.?
Right. So I'm not aware of any Canadian research that specifically looked at the question of the cost effectiveness of ACP interventions, advanced care planning interventions. I know there are observational data from, I think it's largely the United States, that have shown an association, so not necessarily causation, but an association that certainly suggests that advanced care planning or end-of-life conversations in general are linked to lower health resource use, lower healthcare costs. So I think that there's signal out there, and that's, I think, certainly possible. But I would say that in terms of high quality, compelling evidence, I think it's still a question mark.
Yeah. So we did find a few randomized controlled trials that did look at healthcare resource utilization. That was one of our secondary outcomes, which we didn't present here. But in the ambulatory care setting, you imagine it's one of the harder areas to track these sorts of things, because you're basically meeting with people when they're well and then trying to figure out what are their healthcare costs at the end of life, which can be many months. And so the studies that did look at it usually followed people for usually 6 months to a year. And actually, even despite that, they did find a reduction in overall healthcare costs. Pretty much every study did, but we didn't pool the results because there's a lot of heterogeneity in terms of how they measured cost, fixed, direct, indirect costs, and these sorts of things. But there does seem to be RCT level evidence, albeit of, again, we said we ended up judging it to be of low quality, that it can reduce costs. The other thing is that in the inpatient intensive care unit settings, because the time differential from when you have your goals of care discussion and you start discussing end of life and what patients want, the time differential between that and when the resources are used is much smaller. So the ICU level studies, there's actually many more studies that look at healthcare resource utilization then, but that's, I think, mostly a function of the fact that it's easier to measure than it is in the ambulatory care setting, where you could theoretically have to follow someone for 10 years until they die.
And can I ask Simon, if it's John here, we may still be crunching the numbers on that, but your kind of overall impression in the ICU studies, was there a signal that these interventions reduce healthcare costs in the ICU setting, or it's unclear?
I'm just looking at here.
Sorry to put you on the spot.
Yeah. So, I mean, it looks like not as much, actually. It doesn't look like there was as much of an effect on financial cost, but in terms of length of stay, duration, mechanical ventilation, it seems to be. So I mean, we're still crunching these numbers, as you said, but it looks like it results in fewer ICU stays, shorter ICU stays, shorter hospital length of stays. But costs were not different.
So if we define it as an overall healthcare burden, potentially it would be lower, but we're not specifically looking at dollars.
So stay tuned. More to come on that one, I guess.
Okay, I think we could go on for at least another couple of hours, but we're running out of time, and I think people have to get back to work. So thank you, everyone, for attending today's webinar, and thank you again to our presenters. Please visit our website for future webinars to register. And that ends our webinar today. Thanks.
Thank you.
Thank you.